It's
Okay,
recording now.
great.
Thank you for the reminder.
Okay, good. Well, let's begin, ladies and gentlemen. Well, first of all, good morning, welcome. And for those that are not on, oh yeah, we have one or two people that aren't on our board. Let's just share a few things. We are the Community Advisory Board, known as CAB. This board was established by the Community Corrections Partnership, which is known as CCP. Let's now set the table for board members and for those of you in the audience with some housekeeping items. For those in the public, please keep your participation on the mute button until called upon or by raising your hand. For those on the phone, please use *6 to mute and *6 again to unmute. We'll hear comments first from board members and then from the public. Let's pause a moment to review our purpose, which is to provide and advise CCP with assessing, let's do that again. We want to review our purpose, which is to advise CCP by assessing the implementation of the County Reentry Strategic Plan. Some of our responsibilities, but not all, are reviewing data on realignment outcomes, advising CCP on engagement strategies, offering recommendations for ongoing alignment planning, advising county agencies regarding programs for implementation in the county, and encouraging outcomes that are consistent with the county's reentry strategic plan. I notice we have quite a few of our board members here, and we are grateful to those who are members of this committee, and we so appreciate and value your commitment. Now, since we've got an active agenda, let's get to today's business. We'll have introductions in the following sequence. We'll first cover board members, followed by staff. Members of the public, if you would like to introduce yourself, kindly do so in chat. That's if you desire. And then after that, we will cover the announcements or general announcements. Let's begin first with board members. My name is Crawford Carpenter. I'm a member of CAB. I've been here about 1.5 years. Ozzy?
Good morning, Ozzy Carter, a member of CAB, and I've been here about 1.5 years as well.
Dale?
Dale Harrington, member of CAB, and this is my first year.
Nicole?
Nicole Green, a member of CAB, and it's been about 1.5 years. Yes.
Okay, Nakenya?
Good morning. My name is Nakenya Allen. I am a proud member of the CAB, and I have also been here 1.5 years.
Lanita?
My name is Lanita Mims. I am here in East County, and I am new to the CAB.
Thank you. Mark?
Yeah, Mark Thomas. I'm in Oakley. I've been a member of CAB since the beginning of this year.
Thank you. And Joel?
Good morning. My name is Joel Nicholson Shanks, Contra Costa College, but new to CAB, I should say, or new to the team.
And welcome again, Joel. And now could we move to staff members, if you'd be kind enough to introduce yourselves. Jill?
Hi there, I'm Jill Ray with the Office of Supervisor Candace Anderson, and I have been here for more than 25 years.
Wow. Oh, wait a minute. Did we get Scott?
We didn't. I just figured maybe there was a message in that.
Yeah.
This is my last meeting.
Yeah.
Okay. Scott Parsons, resident of Moraga and a member of the CAB.
And I also, you see my screen, you know what, Monique, you're gonna have to call because I don't get everybody. Terry, I forgot you, Terry.
Good morning, Terry Dunn, member of CAB recently, and glad to be here. Thank you.
And I apologize for those CAB members that I missed.
I'm
And
going to
now-
hold on to that for a long time.
Okay, Terry. Let's move to other staff. I see Christina.
Yes, hello, everybody. My name is Christina Jackson. I'm with the Office of Reentry and Justice.
Thank you. And Emily?
Hi, I'm Emily Parmenter. I'm with Contra Costa Health Services, the Office of the Director.
And the lady with all the data, with the answers that keeps us on track, Denise.
Good morning, everyone. I'm Janice Sabkevich. I'm with the Office of Reentry and Justice.
Okay, and Patrice?
Morning all, Patrice Guillory with the Office of Reentry and Justice.
And I hope I didn't forget anybody. If I have, I apologize. May we then move?
I'll introduce myself,
Yeah.
Crawford.
Oh,
Monique.
yeah, Monique. Oh,
That's
geez.
okay, no worries. Monique Tate with the Office of Reentry and Justice.
Okay, Monique, going forward, would you handle this, please?
Okay,
Because
I
I
was-
can't.
I was multitasking, so I didn't realize you hadn't called Scott and Terry, but I will definitely be your assistant with that.
No, you're going to be my lead.
Okay,
Do we
Okay,
want to
then.
also introduce Charles? And I'm not sure if we got Mark Thomas too.
Yeah, we got Mark.
We got Mark. Okay.
We
Charles?
didn't get Charles, please.
All right. Good morning, everyone. I'm Charles Brown with the Workforce Development Board. Nice to be here.
And thank you, Charles. And we apologize again for stumbling, Charles, but we'll do better next time.
No worries, Crawford. Appreciate your
Okay.
efforts.
Okay. We're on item, we're still on item number 1 here. Are there any announcements that need to be made?
I actually have one, Crawford. I
Yes.
just wanted to share with everyone that typically every other month, ORJ hosts what we call our AB 109 Partners and Providers meetings every other month. And this includes program staff from our contracted community-based organizations, as well as our county reps, all of whom are working very closely with the AB 109 population, just the reentry population in general. And we typically also invite other agencies who may not be funded through AB 109, but are still have an invested interest in serving the reentry population. So our next meeting is scheduled for July 26th at 10 a.m. It is a virtual meeting. We also often share some CAB updates, such as your meetings that you have coming up or any surveys that you might want to share with folks, or any information that we know that's being discussed here that's prevalent to the work of those agencies. We do share it in that forum. So I do just want to share with all of you in case any CAB members are interested in attending and just wanted to peek your head in to see what's being discussed. So let me know if that's of interest to you, and we can send the link to you so you can attend. We'll have to monitor the number of you guys who attend to be sure we don't hit quorum, but nonetheless, it is open for your attendance.
Thank you, Patrice. Are there any others that have any general announcements?
Can I give a shout out? It's Lanita.
Yes.
I want to give a shout out to Charles Brown. I went and attended the Workforce Development Job Fair for 2022, and I took about 4 other people with me. 3 of them were looking for jobs, job seekers, and so it was very well attended, and it was also one of the best job fairs that I've been to in East County in a long time. So thank you, Charles.
Thank you, Lanita, for the kind words. Yeah, it was a fantastic event. We were definitely overwhelmed with the attendance. We had 500 individuals register, and actually about 425 actually show up. Combination of unregistered walk-ins and registered. So great event. Thank you for the support.
Are there any other announcements or comments or shout outs? The door is open.
Good morning.
Yes.
I'd like to
Awesome.
make an announcement. As a member of Alcohol and Other Drugs Advisory Board, we're actually co-hosting an event with the Public Defender's Office, a clean slate event this Friday at the Ambrose Center from 9 until 3. We will also be affording free haircuts. So if there's anyone in your community that needs to have a record expunged or needing to obtain rap sheets or any other thing pertinent to expunging criminal records, I'd like you to pass that information on. And I'd also like to thank other members of the board who actually assisted in getting the word out about the event that's tomorrow. Thank you.
Any other announcements? Thank you, Ozzy. None being heard, let's move to item number 2 on our agenda. Public comment on any item under the jurisdiction of our board. That's the Community Advisory Board and not on our agenda. Not hearing any. Let's move to the next item, which is agenda item number 3. Please go to attachment 1, pages 4 through 7. This is where the minutes of our previous meeting on June the 9th. We will give you about 45 seconds for those that didn't have a chance to quickly scan. And then we will call for an approval, a motion to approve, and a second, etc.
I would like to make a motion for the approval of the Community Advisory Board general meeting from Thursday, June 9th, 2022.
Is there a second?
This is Dale. I'll second it.
I have one issue.
Yes, Mark.
Yeah, I thought I was present last meeting, June 9th. Has me as absent. Was I missing? I remember missing any meetings.
You were there.
Okay.
I'll make that update.
Thank you, Mark.
This is Dale. I second the motion.
Is there any discussion by the board? Is there any discussion by the public at large? Monique, would you please call the vote?
Yes. Okay. Crawford,
Aye.
Dale,
Aye.
Ozzy,
Aye.
Nicole,
Aye.
Lanita,
Aye.
McKenya,
Aye.
Scott,
Aye.
Mark,
Yes.
Terry,
Aye.
and Joel.
Aye.
Motion passes unanimously.
Thank you. We had a motion and it was passed. Let's move now to the next agenda item. And we're on agenda item. Could you make that a little broader so we can see that a little better for those that are older? Thank you. We're now on item number 4. And here we're going to have a presentation. And we're pleased to have Emily Parmenter with us, this morning to provide some information pertaining to CalAIM. Emily, the floor is yours.
If I can interject really quickly before Emily gets started, Chair, we're really happy to have Emily here from Contra Costa Health Services, the Director's Office. She is the project manager on all things related to CalAIM and its implementation here in the county. And so what she will be sharing with us per you guys' request is giving a broad overview of what CalAIM is, and also the specific elements of the justice initiative that most of you all have been asking a lot of questions about, and certainly wanting to know where we're headed next. So I'm happy that she was able to make herself available today. And Emily, let us know if you would like us to give you the ability to share screen, if you like to be in control of the slides. Otherwise, it's just what we have here is the PDF version of your presentation and the agenda.
Yeah, I think the PDF version's fine if someone's able, and I'll just let
Okay.
you know sort of when to advance.
Okay,
That's okay.
sounds good. All right.
Thank you. Thanks, Patrice, for that. And I thank you all for the opportunity. I'm glad that we're able to share. And as mentioned, my name's Emily Parmenter. I'm a project manager at Contra Costa Health Services in the Office of the Director. And I'm working across all of our CalAIM initiatives. So my plan for today is just kind of go through a high-level overview of CalAIM, and then we'll dive into the justice involved initiatives. So great. Yeah, we can go to that second slide. So CalAIM, just back up one maybe. CalAIM in general stands for California Advancing and Innovating Medi-Cal. It's a multi-year initiative from the state, the Department of Healthcare Services, to improve quality of life and health outcomes for Medi-Cal recipients. So this is through broad transformations and reforms within Medi-Cal. Overall, the proposal was about 350 pages and included about 22 unique projects, such as areas of mental health reform, substance use, population health, as well as the justice involved efforts that we'll talk about today. The next slide. So I think just in general, there's these 3 core areas where all of those projects somehow fit under one or multiple. The first one being implementing a whole person care approach to address social drivers. So there's a number of initiatives supporting social needs such as housing.
Excuse me, Emily, I'm going to bring up your actual PowerPoint as opposed to the PDF. Okay, let me just change that real quick. Thank you. Sorry about that.
Yeah, no problem.
Okay, I think that might be better to view.
Perfect. Yeah.
Okay, is this the slide we're on now?
Yeah,
Or is it?
this is perfect.
Okay, thank you.
Yeah, thanks. This visual is from DHCS, and it sort of highlights their full landscape of the CalAIM program in general. Sort of starting at the top, we have the population health management, and this is a really large initiative aiming to use data as well as screening tools to identify, potential risks that individuals are facing as well as current needs. So using data to stratify the population and then identify, which individuals might need additional supports and services, and which individuals, really should be focused on the prevention and wellness activities that Medi-Cal provides. So sort of moving down to the center of the visual, you see the enrollee sort of surrounded by these 6 puzzle pieces, those such as physical health care, oral health, behavioral health. Those are some of the core systems and services that an individual is going to interact with during their, lifetime or their experience with Medi-Cal. And sort of below that, in the areas of enhanced care management and community supports, those are new services for individuals who are most in need. And the enhanced care management is a new person-centered care management program. It's really targeting the highest need individuals in the 6 populations of focus that you see listed at the bottom. So this is an in-person case management services, where really the individual is assigned to a new case manager. That's the single point of care, sort of the single quarterback, if you will, across all of their different health and social services needs. Sort of the bucket I want to call your attention to is down at the bottom, people who are justice involved. That's one of the target, the populations of focus for that enhanced care management new service. We'll talk a little bit more about that later. And then community supports you see in the sort of bottom right corner. Those are new tangible services that managed care plans are providing, such as housing supports, medically tailored meals, medical respite. There's about 14 different unique services, which are meant to support the health as well as the health-related social drivers, such as food insecurity and sort of, additional to round out their Medi-Cal coverage. Next slide. Kind of these 7 broad buckets when we talk about CalAIM in general that are most impacting to our system. I think the one that we'll focus on today is that 5th bullet around the services and supports for the justice involved adults and youth. I think maybe just to touch on a couple of the other ones, the behavioral health delivery system transformation really is aiming to streamline policies to improve access. So changing, who is eligible for specialty mental health, reducing barriers to entry, removing things like screenings and specific targeted assessments that were required to make it a more inclusive access process. All right, next slide. So let's dive into the actual justice involved initiatives. This kind of is, I think, probably the best visual of all of the different justice involved projects and efforts that are included in CalAIM. We sort of start on the far left with, during the stay in detention or the incarceration, that there's a new pre-release application process. So the expectation that we start with identifying individuals who are eligible for Medi-Cal, assisting them with completing that application, and then actually while they're still within the facility, beginning to be able to provide Medi-Cal services. So 90 days prior to release, that would allow their Medi-Cal to essentially be activated for a limited number of services, but then that would facilitate behavioral health linkages. So individuals who are receiving behavioral health services within the facility could sort of have that reentry plan more established and set up to transition post-release. And then sort of continuing down this pathway, we have enhanced care management, which is that new enhanced intensive case management service, the community supports, which could support things like housing deposits, medical meals, day habilitation programs, and then continuing on the reentry continuum towards additional reentry supports. So we're going to go into each of these kind of puzzle pieces here. Next slide, please. So the first one is the pre-release Medi-Cal application. So the target here is that each county jail, as well as the youth facilities, will have a new a new process to screen and assist individuals with Medi-Cal applications prior to release. This process already happens within the state facilities. So that's sort of why we're not touching that here, but if we had that in our county, that would be included in scope 2. So the goal is ensuring that individuals are really set up upon release to have their Medi-Cal activated and begin to be able to receive services. The next slide, please. Oh, can we go to the next slide, please?
Emily, can you hear me?
Yeah, I can now.
Okay, I changed it to full screen. Sorry about that.
Oh, no problem. This looks great.
Okay, good. So are we on the next?
Can we
screen?
move forward? Yeah.
Sure.
Thank you. The second one that we touched on earlier is the 90 days pre-release service. So this would be essentially the ability to activate an individual's Medi-Cal while they're still within a facility, so up to 90 days prior to release. This would support reentry planning, really allowing case managers, other providers to come into the facility to provide services directly. The state is currently negotiating with CMS, the Center for Medicare and Medicaid Services, for the ability, they need a waiver to be able essentially to turn this on. They're hopeful that that will come through. Currently, this was scheduled to begin in January, but we don't yet know sort of the new timeline. They've just let us know that this likely will be delayed while they finish those negotiations. But that's sort of the 90 days pre-release service. Next slide, please. Behavioral health linkages, we've sort of termed this warm handoffs. And the goal of this would be for individuals who are receiving either mental health or AOD services while in the facility, that they're set up for a warm handoff after release. So, there could be an appointment schedule. There's a clear plan for who the provider to provider transition is, so that individuals aren't sort of left on a cliff or left to do this on their own whenever they're transitioning out of a facility. And again, this is both for the adult as well as the youth facilities. The next service is enhanced care management. And my apologies for the slide. I'm not sure how I missed that overlapping visual when I sent that. So that's my fault. This is a new high intensity case management service. There are 7 target populations. Of this, there's about 4 that are currently live. There's sort of a transition plan to bring on youth and complex children next summer, as well as populations around long-term care in January of this year. We actually are live with the justice-involved population for adults within our county now. So managed care Medi-Cal members are eligible. They can submit a referral either themselves, a family member, or a provider directly to their health plan. So within Contra Costa, those of you who might have been familiar with the public health whole person care program, which was known as Community Connect is now an enhanced care management provider. So individuals who are enrolled in this high intensity service are receiving case management services today from the public health team. If the individual has Kaiser as their managed care provider, they're receiving the service from Kaiser. They would be eligible, I should say. So that's the service now. It's really just on top of all of the other services. And in many cases, the individual can continue to receive care management from other programs. So maybe they're receiving case management from behavioral health after release. They can coordinate with the new enhanced care manager, case manager as well.
Hey, Emily, would you like questions during the presentation or once you've completed?
Either are fine. Yeah, is there a question?
So Jill has her hand up.
Hi, I just had a quick question. You don't have to back up the slides, but when you were talking about the CMS negotiating authority, you're only talking about the state prison system, right? Our jails are fine.
No, that would be within our county jail and county juvenile hall facilities as well.
Okay.
Yeah, the state will need a waiver in order for Medi-Cal to be active during that period.
Okay, so that's what you're talking about working on, okay, thank you.
Yeah, we're really hopeful because that I think supports the success of some of these other initiatives. As you can imagine, having the enhanced case manager assigned while someone's still within the facility would be a really great transition and support, as well as the behavioral health warm handoff. So if Medi-Cal is active, we could get those future appointments scheduled. So I think the state really sees how those are integral, and they're working very hard to try to get that quickly. But great question. Thank you. Please, anyone, ask questions. All right, let's go to the next slide. So sort of just to talk locally, where we're at in terms of implementation. I touched on the timeline for a couple of these that are coming up. We can go to the next slide. I'm sure much of this information is already very familiar to you, but I think as we started planning and thinking about CalAIM earlier this year, we sort of wanted to understand who's currently being served within the jails and the juvenile facilities, across the state. About 1/3 of the individuals in prisons and jails have some level of mental health diagnosis. And that's completely in line with what we see locally, where there's about 30% of adults in detention who receive mental health services. 1/3 of those individuals booked in the adult facilities in the last year reported some type of substance use disorder needs. And then in terms of reentry, thinking about what's the size of population reentering, there are about a little over 3,700 individuals who re-entered, and then about 250 youth and young adults from our juvenile facilities since January of 2022. So that's just in the first half of this year. And then 86% of individuals booked in detention already have Medi-Cal, or they had no insurance at the time of booking, and so they might be eligible for Medi-Cal. Next slide, please. So looking at our implementation priorities, the goal is really to disrupt the silos and try to use this opportunity to streamline, to facilitate collaboration across the different systems, and then coordinating, addressing additional service needs of these target populations, and then leveraging all those aspects of CalAIM. So I think sort of at the beginning, we touched on the enhanced care management, as well as population health and the community supports pieces. So those would be additional services to address specific needs such as housing, or there's even a medical respite, for a temporary stay, building the capacity around this. So that means things like data system connections. So how do we get the justice, the JMS system to talk to the health system, and how do we connect that to social services, and sort of using this opportunity to build that infrastructure, not only for now, but for the long term. And then finally, really shifting from referrals to the actual linkages to services. So not just giving someone, a list of potential providers, but actually, setting them up, doing that warm handoff, ensuring that, the individual is set up for as much success as possible post-release. And really, the goal being to ensure a successful transition back into the community, with the expectation that those successful connections can decrease future reincarcerations and future negative interactions. Next system. Just wanted to touch on the current reentry activities in place. So reentry services have resumed to pre-COVID levels. Currently, there's a behavioral health financial counselor that works within the facility to submit and reinstate Medi-Cal applications. So individuals who are screened today are connected to behavioral health. I see a couple of hands. I just noticed those. Can pause, Denise or Terry.
Yeah, hi, Emily. I'm on your previous screen, you talked about disrupting silos and building system capacity for implementation of these programs. And I'm wondering, given that this is for a reentry population, how you were linking with probation and probation services in order to do that, and particularly as it relates to disrupting the silos, as well as providing more wraparound services and supports for individuals, maybe post-treatment, but while individuals are still on probation.
Yeah, great question. We actually have probation right at the table alongside the other partners. And I've got a slide that sort of visualizes our governance structure and then where those teams come into play. So I think I'll get to answering that in just a couple of slides, if that's okay.
Okay, of course. Thank you.
A couple of slides ago, you had 86% of folks either with Medi-Cal or uninsured. Do you have a sense of how that breaks? How many of those are uninsured? I understand that they're both folks who could use Medi-Cal services, but
let me follow up on that.
Okay.
As I was looking at this morning, I thought, we should have split that out. We can get that data though.
And I will just, as a side note, if they have Medi-Cal stops once they're incarcerated. So I think that's why it's lumped together. So essentially, once they get incarcerated for a specific period of time, basically 86% has no coverage. And that's the
Yeah.
importance of linking them to Medi-Cal prior to exiting. I think that's why it's lumped together.
Yeah. That makes sense. I just, those who had Medi-Cal at least have some experience in the system. So that's why I was thinking of them a little bit separately. Thanks a lot.
Yeah, thanks. Great questions. And thank you, Jill, for clarifying that. Yeah, when individuals enter a justice facility, their Medi-Cal, if they have it prior to coming in, is put on a suspension status, and that suspension can last up to a year. And then upon release, the suspension is lifted, and so it's fully reactivated. There are certainly challenges, just to that logistical process, and so that's a partnership with social services, our EHSD, Employment and Human Services Department. That is also part of our core team here. So we'll touch on that too. And so let's see, re-entry activities. So just sort of refresher of what's currently in place. When we're aware of a pre-release within the facility, a 30-day supply of medications is requested. The team works as hard as possible to fill that prescription. Sometimes those releases happen quickly, and so we can send an electronic prescription to a local pharmacy if there's not enough time to fill that within the facility. The remedy groups are currently being held by the transition clinic after release. And then within the facility, reentry groups are currently being held on the F module, and then groups are being piloted at West County as well to expand that. All of these services we recognize can be expanded and improved, with the help of CalAIM. So moving on to sort of the partners are critical to this work. One of the key challenges in sort of across the country is the silo that exists between the criminal justice system as well as, the health and the supportive systems that support these individuals. So we're bringing together our sheriff's office, the probation office, EHSD, which is Employment and Human Services, the Behavioral Health Department, as well as Public Health, and then our managed care plans in the county to help reduce these barriers, allow for data exchange, sort of leverage the resources that exist. So this visual sort of shows the full process of, what the CalAIM work will touch for an individual involved in either the county jail or the youth facilities. So kind of starting at intake, how they might receive behavioral health services, and then sort of the boxes around them represent the different teams and departments that are involved in that. So sort of above the whole thing, we see the sheriff's office and the probation departments, and then detention health, which is currently provided by Contra Costa Health Services, is with that individual during their stay within the facility. And then the EHSD has a role in processing applications, activating, as well as suspending benefits. The behavioral health department supports those individuals as part of the specialty mental health for the individuals with a moderate to severe diagnosis. And then enhanced case management, as noted, is provided by Public Health. That's currently in partnership with the behavioral health department. So they have teams co-located together. And then the authorization and payment of the Medi-Cal services. So the Contra Costa Health Plan covers the majority of managed care individuals in our county. They do have a small number of members that are Kaiser, that they sort of sub out to Kaiser, if you will, individuals who had a previous relationship with Kaiser. I will also say that we have Anthem Blue Cross in the county as well as a managed care provider. And so they would be expected to also be providing these services as well. So we have kind of our overall governance for CalAIM at the county. We have an executive steering committee that supports all of the different initiatives. So from population health management to the behavioral health payment reforms, that group sort of sits at the top. And then below that, we have a number of sort of sub structures in place. So for the Justice Involved Steering Committee, we have a team, a work group focused on the pre-release applications, which includes representatives from the Sheriff's Office, probation, EHSD, as well as health services. And then ECM, that Enhanced Care Management Group, also has similar representatives from those departments. And the Behavioral Health Warm Handoff Group focused more on the mental health and AOD providers within those domains. And then the last work group is PATH, which PATH is a incentive-based funding stream for these justice-involved initiatives. So there's an amount of money that's available to build capacity within the facilities, to support infrastructure development, such as data connections, could be a physical hardware purchase, in order to have success across these other initiatives. I think that's the end of it here. There's my contact information, and then LaVonna Martin, one of our deputy health directors, is leading up this initiative. And she was unable to be here today, but she's also a great resource for additional questions.
Denise, I believe you have a question.
Yes, I do. Thank you, Crawford. As Crawford introduced me earlier, Emily, I'm the data person in our unit as it relates to our reentry and probation populations. And I wonder if you could elaborate a little bit more on what the intentions are for sharing, some of the data that you had in the diagram. I noticed the diagram a couple of slides ago shows you have information from the sheriff's office that comes from detention, and then there's really no link in there for what the role is for probation and how this information could be useful to the probation department in supporting some of the needs of individuals in the community that need just mentoring support or anything along those lines. And I'm particularly speaking about those individuals with behavioral health needs, because what we know for sure is that, residential treatment or treatment can take place, and then because of the nature of behavioral health conditions, as I know you already know, they're chronic, and we need more kind of community care for that may be a place for probation to provide additional support. And I just wondered if there were conversations along those lines, as well as, what the intentions are for data sharing with probation to support this effort.
Yeah, I mean, I think sort of going back to the core focus is to improve that transition period. So for individuals who are receiving those behavioral health services while within the facility, it would be to connect them while they're still in the facility. So before that they are released, getting that connection to a behavioral health provider, to a program outside of it. So the data sharing would be, so far, I guess I should say, it's been focused on, how do we identify individuals who are receiving these services within the facilities? Mm-hmm. And then who does that connection need to go to outside of the facilities? And so, a number of those kind of the core providers are health. And I think the question comes in, what are probation systems today? What data do they need to have? And so we're still just kind of in that initial current state mapping, identifying the challenges. I will say we have found that there are some of those teams and departments are a little more advanced technologically with the tools available to them than some of the others. So I think that's where we're hopeful that some of the PATH funding could help to close those gaps and maybe move some of them off of paper onto electronic systems so that they could have, a notification of this individual received this service while in the facility, and here's their connection plan and their treatment plan for post-release.
Yeah, I think I'm feel disappointed, I should say, maybe directly, that probation is not considered one of the core services from the standpoint of individuals being released. And while health services are all clearly, and social services are clearly a major part of whole person care, I think for individuals that are justice involved, and this is a justice involved population that we're talking about, to not consider probation one of the core systems and entities involved with services, because our unit has a lot of engagement with individuals, is I think that could be a gap. So I just throw that out there for your information and my perspective. I'm sure that Patrice might have other thoughts as well as the chief, but it does feel like that's a gap to me.
Thank you for the feedback. I mean, I will say probation is at the table, and they are a core partner. You know, the initiatives under CalAIM that we are charged with implementing are focused on that behavioral health connection. Outside of it, the connection to the other CalAIM services, such as enhanced care management. And probation is a core partner, and they are there with us. So thank you for the feedback.
Thank you. Thanks.
Thank you, Denise. Oh,
Dale
thank
has
you.
his hand up next.
Yes, I was going to say Dale.
Okay.
Sorry. Okay, you got it then, Monique? Okay.
I think Patrice, I think Patrice should go first because she may enter into this topic here.
Okay.
And then I'll go afterwards.
Okay, thank you, Dale. Emily, great presentation. And I actually have a couple of questions for you that might help illuminate some things for all of us. One is that given that this is a state mandate, and each county or each location is really, or jurisdiction is really trying their best to implement this while understanding their current processes and systems, how they're currently operating, right? We, as you may know, have as a kind of extension of the criminal justice system, we have this sort of system of reentry service providers, where you have both county agencies as well as contracted community-based organizations who are providing resources to folks who are justice system involved, providing that wraparound support. Oftentimes, well, before COVID, it was both while folks are in custody as well as out of custody. So I'm curious to know that as the various working groups are working through how to best implement this initiative, is there any flexibility around how we best coordinate or create these new processes in conjunction with already existing service provision that are really touching on very similar things that CalAIM is asking counties to take into consideration? So for example, in your diagram of the CalAIM partners, there's EHSD, there's that's handling, Monique, do you mind going back to that slide? It was on the CalAIM. A couple more. Yeah, this one, perfect. Okay. Yeah, EHSD processes the applications, VHS has the warm handoff, and then, around the 90-day services pre-release that goes straight to the enhanced case management. So I'm not sure if you're familiar with this, but we support a program called Game Plan for Success that's offered through Office of Ed, right? That's then in the facilities. And this is a program that has been in existence now for, gosh, a few years, offering the this pre-release planning in connection to, or navigation, if you will, to both services within custody as well as out prior to their release. And initially it was a pilot project supported by the county, really only focused on individuals with a 90-day release date. That has since changed, where they're really trying to touch really everyone in the jails. So that's just one example, right, of a program or a process that was sort of already in place. And with CalAIM coming down the pipeline, that I think actually enhances a lot of that work and better connectivity between some of these partners. how then do you adjust to also incorporate some of the programming or services that are actually, that we find to have been very successful? We don't want to lose sight of those as well.
Yeah, I think that's great to highlight that, there's so many wonderful things that are happening, and CalAIM has a lot of flexibility. There are some things where there's a mandate or, a requirement, a deliverable that we need to meet. And, many of those are focused on the Department of Healthcare Services, sort of their focus, if you will. But yeah, I think there's certainly the ability to coordinate and to collaborate more and, identify what's working well and what's not, and use this as an opportunity to improve, to scale those additional efforts as well. I will say this visual here doesn't really cover, that reentry connections and services that aren't related to behavioral health care or activating the Medi-Cal benefits. So I think that's certainly a piece that we need to update and to look to who are those additional partners to bring in here.
Great, thank you.
Emily, are there many persons who do not qualify under CalAIM? And if so, is there a primary reason why they don't?
For the justice involved initiatives within CalAIM, it's really, are they a Medi-Cal managed care member? And if they're not, are they eligible for Medi-Cal? The entire program is funneled through the managed care plans. So, from the state's perspective, to be eligible for these services, you would need to be, either a Medi-Cal member or eligible for Medi-Cal.
Yeah, okay, thank you.
And then I guess, Jill, excuse me, Emily, you were going to say something.
Yeah, I was just going to say, some of the additional services, such as the behavioral health connections or the enhanced case management, there are additional eligibility criteria for those areas. For behavioral health, you obviously would need to qualify for specialty mental health services. And enhanced case management has, an additional need, some type of like a social need or a complex health challenge as well. So there could be additional eligibility criteria beyond just a history of justice involved.
Thank you, Emily. And now what do you do? Jill, followed by Denise.
Yeah, so I'm going to piggyback on what Patrice was just saying, Emily. And I just wonder, has there been sort of a map done to determine what services are happening right now? Because like Game Plan for Success is doing almost entirely what this aims to do in the pre-release. So wrapping them into the program versus trying to stand up something new, I think is critical. They really worked through the kinks and created a program that's phenomenal. And I wonder, and with Lavana sort of overseeing this, I think is a fantastic thing because she's been every step of the way through much of this, like the sequential intercept mapping that we did through Patrice, help me with what that was called.
Stepping Up Initiative?
Yep, the Stepping Up Initiative sort of laid out what we had several years ago as far as the system goes across the board from zero intercept to, release. And so I'm wondering if that's been brought in to kind of recognize what, and there have been more services provided since then, but at least it gives you a starting point to kind of determine, so that way we're not missing anybody through this process, because I think it can only help to bring these people all into this process to bring more services.
Yeah, thanks, Jill. We have talked to the Office of Education, and so we do have them, that service as part of our full map, this sort of workflow. But I think there's certainly the opportunity to bring them in further and to, really highlight that full reentry service line, which I don't think is represented here.
Yeah, and pulling the SIM, because that was really the connection of mental health and the criminal justice system with the goal of, decriminalizing mental health issues.
Thanks.
I think there was another, just before we get to you, Terry, Denise, you had your hand up, or there you are, Denise.
Whoops, I did, and then I took it down, but then
Yes.
Jill gave me the perfect segue to my one of my other questions about the mental health and the behavioral health kind of needs for the population that we're looking at here. And Emily, I hope you're going to be able to stay on after we're done with your Q&A, because Christina's going to present some of the findings from our Community Advisory Board survey. And one of the findings that has come about is the critical need in the county for behavioral health, mental health, and AODS kind of service providers and clinicians. And you know, we're having trouble with forensic mental health clinicians filling our MET teams. And I'm wondering, you know, strategically, if you're seeing that on the ground for these services, and also if there's anything that's going on to ramp up that behavioral health clinicians. And I know that this is a need not just in our county locally, but I understand it's a statewide, it's a nationwide, it's even a broader international issue, because the mental health needs are just, and the AOD needs are just growing, and yet we can't seem to find or keep clinicians. And I wonder what your thoughts were, and if this initiative is in any way trying to look at creative ways to bring on new staff if we're going to be building this out further.
That's a great question. And I think I've definitely a very known a need. Unfortunately, I don't have an update on that, but I can certainly pass that on to Suzanne Savano, our behavioral health director, who's a key member of all of these initiatives as well.
Thanks.
Thank you. And wait a minute, we have one more here. Dr. Cole, thank you for joining us.
Hey, thanks, Carpenter. And just as an insight, and I've been on the super internet highway trying to get here, and I have to jump right back on in 4 minutes to get to my next meeting. So just real quick, Emily, and you may have touched this already. This is a two-pronged question. Cal AIM versus whole person care, challenges and also improvements. And the other part of that is, how are you all dealing with social determinants of health? You may have already spoke about that. How does that apply moving forward?
Great questions. So the whole person care pilot, as you may know, ended December 31st of last year. And many of the sort of findings and benefits influenced Cal AIM and influenced the development of the enhanced care management program, as well as the population health management aspect of Cal AIM. I will say it's not a natural sort of continuation. I think whole person care was much more focused on the social determinants and sort of a social needs case management type of program, which still exists, but the enhanced care management new benefit, which sort of replaces that, builds on it with a medical acuity case management model as well. So it's a higher intensity case management program now that replaced whole person care, as well as a more acute population. Whereas with whole person care, especially in Contra Costa, we really focus more on that rising risk population. And we're able to have a really large case management program that had about 12,000 to 13,000 individuals enrolled at any time. Enhanced care management is much smaller and a higher acuity population. And it has these kind of 6 target populations of focus, including a justice involved. There's also one for the homeless, one for foster youth, sort of those are complex children, I should say. Kind of so more targeted, higher intensity, I would say, is the transition from whole person care. And then social determinants of health. The state has an initiative under Cal AIM called Population Health Management, which seeks to use both data as well as social needs screening tools to have every plan, so essentially every county and then the Medi-Cal managed care plan within that, collect this information to risk stratify all of their individuals, their members into different tiers. So based on risk, and then align those to case management services or prevention and wellness needs as well. So yeah, I'd say the social determinants sort of focusing on that risk stratification and expanding it to the full population versus just having it be narrow to the whole person care case management domains only. There's also community support services. I'm not sure if you were on for that area of the presentation, but there's essentially 14 additional new services that managed care plans can offer regarding like housing supports. They can support housing navigation or tenancy sustaining services, housing deposits, medically tailored meals, asthma remediation within the home. That those are sort of new tangible services that plans can offer in support of these social determinants. So that's sort of where the state has gone with both of those initiatives.
No, Emily, I thank you for that. And that really explains a whole lot. And on the service provider side, as you mentioned, does it make it easier for their billing components to extend access to those services that may not be out there for individuals up under that scope of social determinants of health?
Yeah, that's a good question. So with CalAIM, all of the sort of the program in general is now funneled through the managed care plans. So managed care plans are able to contract with community providers, with health system providers in order to provide those services. And then all of those services are essentially billable to the managed care plan, who then, sort of passes that bill on to the state, that claim, if you will. I think there are some challenges, and now, community providers needing to navigate the Medi-Cal, billing system. But for the individual member, it should not be a barrier there.
Thanks for that, Emily. Great information. Thanks for the support. Everybody, I have to jump off. I'm sorry. Thank you.
Thank you. Okay, Patrice.
Yes, sir. This is, first of all, just know, Emily, this is a great indication of how great this information is and your presentation is. So thank you. But just one quick follow-up question on the last comment you made about the managed care plans can now, I guess the beautiful thing about this is that in its expansion, there's now more services that can be funded and covered for. However, if the managed care plans are doing their own, are contracting with their own, I guess, select group of service providers, particularly in the spaces of housing, this is what I'm thinking about, then for the other organizations or agencies that are doing similar or providing similar services, how do we make sure that we are not duplicating efforts, or yet again, maybe not we may set ourselves up for not having a really great coordinated system, particularly for this population. Well, I would say all of those vulnerable populations, but specifically the justice involved folks.
Yeah, I mean, I think that's a real potential challenge. And I think that's the role that Contra Costa Health Services is trying to play, sort of to look at the broader landscape of what's required for CalAIM, what's the role of, the Contra Costa Health Plan as well as Anthem in these services, and then what's the broader landscape? There are individuals who aren't covered by managed care Medi-Cal that need these services too, and that the health department will continue to provide services to that. So I think that's definitely a challenge. And I think there's the opportunity to, sort of pull up and look at that more broadly too.
Thank you. Well, Emily, you have you have done a great job in sharing information, and I want to thank you for taking the time to visit with us. And Emily, hopefully you'll be able to stay with us, and we'll move to our next agenda item. And that agenda item is going to be our much anticipated survey analysis of our CBOs and governmental partners. Christina, go get them.
All right, sounds good. I'm going to go ahead and I'm going to share my screen and pull up my presentation. Just 1 second here. Okay, how does that look? Can you see the slides?
Yes.
Yes, okay, perfect. And if I don't see any hands, just feel free to stop me, Crawford, Denise, Monique, and I'll slow down and we can answer questions. Okay, so good morning, everyone. For those of you who don't know me, my name is Christina Jackson. I'm one of the planner evaluators in the Office of Reentry and Justice. I'm delighted to be here with you today to discuss the findings of the CAB Programs and Services Subcommittee's AB 109 survey. I know that the Programs and Services Subcommittee has already received some high-level updates on the survey over the past few months, but the goal this morning is to peel back some of the layers and present the overarching themes from each question, including some noteworthy comments across all responses and some considerations for potential next steps for this body. Let's dive right in. A quick overview of the survey itself. An 8-question survey was distributed to all county agencies and CBOs funded by the county's AB 109 Public Safety Realignment Revenue. The purpose of the survey is to better understand goals, challenges, and barriers to achieving the programmatic aims of each agency and organization that serves this population. Ultimately, the results from the survey can be used to inform CAB's recommendations to the CCP or the Community Corrections Partnership, which Crawford, you mentioned in your opening remarks. So a few months back on April 26th, the online survey was sent out via email from the ORJ with question formats, including both short response and some longer narrative responses. 17 individuals responded to the survey, representing 15 unique agencies and CBOs. If the numbers seem lower this year compared to last year, that is because the intent was to reach a more targeted pool of individuals whose voices and responses could be represented on behalf of their agency and their fellow staff. Also compared to last year, the survey this year was shortened by consolidating certain questions and making it a more streamlined experience. Okay. So as I mentioned, responses were received from both CBOs and county agencies. On this slide here is a list of the 15 respondents by respondent type, whether that's a CBO or a county agency. The CBOs included Bay Area Legal Aid, Centerforce, LAO, Shelter Inc., MWP, the RSC, and Health Right 360. On the county agency side, there were responses from Workforce Development Board, AODS, the Public Defender's Office, the Sheriff's Office, a Met Police Department, Probation, Health, Housing, and Homeless Services, and the District Attorney's Office. Just give you a quick second to look that over if you need. Okay. So, of the 17 survey responses, 8 or 47% were from county agencies, and the other 9 or 53% came from community-based organizations. So we had a pretty even split in terms of provider representation amongst these two categories, which is really great. Moving on to the region of county served. This graph is showing us the distribution of the county region that each respondent currently serves. We can see that over half of the respondents serve the AB 109 population across the entire county. 4 respondents reported serving West County only, 2 reported serving both Central and East County, 1 serves individuals in Central County only, and 1 in East County only. All right. So now that we better understand who responded to the survey, what type of provider, and which region of the county they serve, now we'll move into our main course here, so to speak, the narrative responses of the survey. But before we do so, a quick note on the methodology, just so it's clear to everyone how the data from the written narrative responses were analyzed to be presented today. To determine key themes that were reported for each question, 2 of us from the ORJ, that would be myself and Denise, independently reviewed and coded all the survey responses looking for patterns. And then we met together to negotiate what we individually considered to be the common themes, and then together arrived at an agreement or consensus on what those final themes were. By doing this first independently and then together, we achieved what is called inter-rater reliability. This was done to prevent any of our personal biases coming through and determining what the major themes were from the responses that we'll talk about shortly. But overall, as has been communicated over the past few months, and as Denise just previewed during the last presentation, the key themes throughout the survey surround needs for more housing, behavioral health services, as well as program capacity issues, such as regarding staffing levels and the desire for increased provision and partnerships. These issue areas appeared consistently across the responses throughout the survey, and we'll go into more detail now. Okay, so starting with our first question. What is the most critical area of need for individuals returning to their communities? Alrighty, so I'm sure no surprises here. The most commonly reported areas of critical needs were housing, employment, and behavioral health. And behavioral health here being a category which includes both mental health and substance use disorders, or SUD. For housing, respondents noted the need for options specific to the circumstances of the individual, whether that be transitional housing, sober living environments, or permanent housing, as well as for pre-release housing planning to get individuals into housing immediately upon release from custody. Stable jobs and income, in addition to increased stabilization facilities, which we understood to mean detox centers, mental health services, and SUD treatment were other areas of critical need. A reminder that these are not the only areas of need reported, but again, the dominant themes that appeared most frequently across the responses. Alrighty. So a quick disclaimer before we go on, I just think it's worth noting that although I have separated these key themes into distinct categories across this presentation, we understand and we know that clearly these issues are not mutually exclusive and each impacts the other in countless ways. They're part of a complex web of needs, and no area is independent from the other. We know that lack of housing can affect employment, which can affect mental health and so on. But for the sake of teasing out the specific areas of concern within the survey and the key findings within these issue areas, we're going to continue to keep them as their own distinct categories. Okay, so we're going to move on to the next question here. What is the greatest challenge your program is facing? Oops, okay. So this question is speaking to current program challenges. And moving from the orange to the darker red on this slide, the greatest challenges we found in survey results were client engagement, then once again behavioral health, and then once again housing. Regarding client engagement, fewer referrals to programming, likely attributable to the COVID-19 pandemic, as well as challenges with staffing and maintaining participant consistency were reported. Within the behavioral health section, it was reported that there is an insufficiency in the availability of mental health and SUD services and workforce shortages in general in these fields. Related to this, the MET, or the Mental Health Evaluation Team program, is experiencing some challenges related to the numbers of clinicians, long waiting periods for accessing the programs, and wanting to actually increase the length of the program service period and to fully ensure, or to ensure that the client is fully stabilized. Since the number of MET teams in the county has recently expanded, this makes the hiring and retention of MET staff an urgent priority to keep to fill and keep these positions filled. And finally, again, we see lack of housing options being a program challenge. Alrighty. So now, what potential areas do you see your program or programs growing into? The first theme is service provision. Respondents reported the desire to reestablish or explore new collaborations and partnerships to enhance their service delivery. Examples we saw in the responses included a potential medical legal partnership or tapping into the new CalAIM initiative we just heard about to integrate and streamline service delivery. It was also noted in the responses that COVID interfered with these potential partnerships. So getting back to a pre-COVID state in terms of collaboration. Let's see, under the behavioral health umbrella, expansion of the MET program again was mentioned, in addition to general expansion of mental health clinicians in our county, as well as providing SUD counseling. Respondents also reported seeing their programs grow in the direction of increased housing services specific to those with mental health and substance use disorder needs. And finally, expanding housing partnerships to potentially increase access to housing facilities for individuals returning to the community. All right. The next question was to describe any barriers that your agency experiences when seeking to reach program goals and objectives. What supports could help your agency reach those goals and objectives? Because this question has two components, I split up the common themes that fell into the program barriers bucket and those that fell into the program supports bucket. And first we'll start with program barriers that were reported. Again, here we see client engagement, willingness, and consistency with program participation reported as one of the barriers. Issues surrounding contacting and communicating with clients also came up. Low referrals was noted once again. And the next section or the next barrier that was reported is related to staffing issues and service capacity. Needing more staff in general to provide this great work was reported, as well as comments about the non-competitive nature of salary levels that may have an impact on staffing issues and retention of staff. Lastly, as we just discussed in the previous question, the lack of clinicians in the behavioral health space, in addition to long wait lists for services, create major barriers. So now the question is, what supports could help agencies? Respondents mentioned once more that reestablishing partnerships across the system, maintaining sufficient staff levels, and obtaining more accurate, better client contact information so services can actually reach those who need it and not be interrupted or stopped by out-of-date contact information. A suggestion that was reported was just to simply obtain multiple points of contact per client in addition to an email address. So there are multiple avenues to take. Another program support that was mentioned, but it's not on this slide, pertains to behavioral health and is related to providing potentially forensic mental health training to officers in the law enforcement agencies with MET teams. So if a clinician is unavailable, law enforcement can still carry out certain tasks related or certain tasks to an individual in need. Okay. So the last question of the survey asked, what programs and services would you suggest that we consider for future development or funding in your area? The top three themes, once again, housing, whether that be long-term housing opportunities, housing navigators, or transitional housing, behavioral health, examples provided included mental health clinicians within every law enforcement agency to provide support in emergency crisis calls, enhance mental health case management and having SUD or substance use disorder treatment in all detention facilities. And then what was also mentioned here was pre-release planning. This was a key theme. There were suggestions here for enhanced pre-release planning to support with securing housing and employment resources prior to release, and also expanding GPS or game plan for success, which provides in-custody engagement, which we also just discussed a few moments ago. Okay, so before I move into potential considerations for the CAB to keep in mind as they move into next steps, here's a quick overview of some of the particularly noteworthy comments across all survey responses. Again, the lack of mental health clinicians. As we discussed throughout this entire presentation, behavioral health was a primary theme that rose to the top in almost every response, and it was noted that not having enough mental health clinicians poses a concern to the MET program, in particular, and the MET teams in the community. One respondent noted that long wait lists for stabilization services impacts the ability for individuals with substance use disorders to stabilize enough or at all to go on to receive other services that they need. We all know that COVID has played a major role in how providers and the entire community has had to adapt. And we know from the survey that it has had an impact on client engagement with the lower referrals in some cases from some of the respondents who noted that. But client engagement issues likely existed before COVID as well. Pre-release planning and service linkage is an important element to creating relationships and trust with individuals preparing to re-enter the community. potentially providing incentives for transportation through Uber or Lyft. That was a suggestion that we saw in this survey. So people can get to treatment services was another point made, which is also related to relationship building. And lastly, staffing capacity issues across both the CBOs and the county agencies presented barriers to programs. And the non-competitive salary levels specifically noted within the CBOs also impact staff retention and thus the ability to serve the AB 109 population. So, given the key themes we've reviewed and the noteworthy comments on the slide prior, here is a list of items that the CAB Programs and Services Subcommittee and the full body may keep in mind for future consideration. This includes considering approaches to retain critical staff needed in the behavioral health fields, including AODS or alcohol and other drugs, substance use disorder, and forensic mental health clinicians or FMHC staff. These approaches may include proposing or advocating for salary increases or bonuses or other innovative angles. For example, a pilot apprentice program between the County Workforce Development Board or WFDB and forensic mental health clinician staff from the community that may have perhaps lived experiences themselves with the criminal justice system. This did not come directly out of the survey, but these are potential innovative angles that we can think about based off of the evidence we found in the survey. Once staffing capacity is at a more sustainable level, then there could be consideration of looking into how substance use and mental health stabilization facilities may be expanded. There could also be consideration of the expansion of in-custody and pre-release planning services to maximize client engagement, and think of new ways to incentivize individuals to get involved and maintain participation in programs. Lastly, it may also be worth considering a reevaluation of the AB 109 budget to ensure that there is alignment in the distribution of funds with the current needs of individuals returning to the community and the needs of our providers. These current needs may not be the same needs that existed when AB 109 was first implemented and the budget first created. So there may be an opportunity to reevaluate whether the funds are being distributed where the greatest needs are. So I'll stop here for now. Before I open up for Q&A, Denise, is there anything you would like to add or throw in that I might have missed from our review of the surveys together?
No, I think you've done a great job summarizing that. I will share one fairly new tidbit. I received just recently some information, the year-end report from the Game Plan for Success program that we were speaking of earlier. And 50%, over 50% of Game Plan for Participant, Game Plan for Success of participants were homeless, over 50%. So, you know, we've known, but this is, it's a really striking challenge for us and continues to be. So I just wanted to share that.
Absolutely. Dale, I see your hand.
Yeah, there are staffing issues for some organizations are related to the inability to get people to apply for positions. So you end up with vacancies that are unfilled. So I'm wondering, is it a combination of that and not enough allocated positions? Is it both of those that seem to be there?
Yeah, that's a great question. And I'll just speak to one point of that, and I might pass it off to others who have more knowledge than I. But I think Denise mentioned this in the previous presentation, that these issues we're facing are not unique necessarily to Contra Costa County. These are big picture issues that we may not have, you know, all the control over, especially if, you know, there's issues with recruitment. Those are big issues that expand beyond our county, beyond our state even. So in terms of, you know, numbers of positions and things like that, I don't actually know. I'm just reporting here what we found in the survey, but if others have more insight, I would love to hear from any others on the call.
Yeah, Dale, that was not, we didn't get into the weeds of that, the rationale for why staffing issues are so challenging. I see it with our providers from the perspective of our Salesforce database, and that there can be some providers have more rapid turnover in staff than others. And why that is, you know, we can't speak to directly, although I think it's fair to say that staff for service providers are, you know, they're not, I'm not sure what the wages are, but I don't think they're, you know, really high level wages. And so there would be some turnover there. And I think that's what we're trying to say with some of these considerations is,
Yes.
how do we incentivize that? How do we incentivize retention? And we know this even with our population that we're serving, individuals can get employed, but it's not obtaining the employment, it's retaining the employment and providing a path for their development. And so that may very well be true for our service providers as well.
Yeah, inadequate wages affects hiring as well as retention, like you're saying. So it's a double-edged sword.
Well, we will be tracking that more staffing turnover in our new performance-based contracting approaches with this new fiscal year and new set of contracts, is getting a sense of, is there turnover, and does the organization have sufficient staff to conduct the services that they have set themselves up to conduct. And so if that turns out to be a problem, we can identify that and work with organizations to think in different ways to ensure that they do have sufficient staff. And maybe it is a funding issue as well. I'm not sure of that yet, but we're going to start working in that direction.
Good, excellent, thank you.
Great.
Jill?
Thank you, Denise.
I'm happy to wait if there's anybody on the CAB who has questions ahead of me, since I am not officially a member.
You're the only hand raised.
I see Nicole.
Right, oh, there we go.
Yeah. So Denise, I just wanted to piggyback as a previous provider in reference to turnover. I was very excited to see the results from the survey. Some of the turnover does have to do with wages, especially in Contra Costa County compared to other counties. The pay is a little bit low in those particular fields. I know when COVID hit, the impact of the pay was looking at, it has to do a lot of mental health and substance abuse. A lot of the individuals in our population, they come out dealing with that. So the staff is looking at how much they're being paid. Their required task has changed now. So they're not only doing just case management anymore, there's no one on site to handle the SUD or the mental health. So we're having a staff of 2 or 3 people that are wearing about 5 or 6 different hats. So it's the same thing that the providers are experiencing now, exactly what the county is experiencing. Since there's no staffing in the county, it is now coming down to us providers to do all of that. So the staff is doing great, but the pay is not keeping them to do that. And then it can be a little bit, it can kind of burn them out. So looking at reevaluating the positions, having someone in our providers that do mental health, that focuses on SUD, as well as the case management piece, can probably help with that retention.
Yeah. Thank you, Nicole. I thought that you might be able to provide some further context.
Yeah, I wasn't sure yet.
I didn't want to call you out and ask if you could you please speak to this?
Yeah,
Thank
COVID
you so much.
taught us taught us a lot. And I can tell you my staff was, they were case managers, they were mental health advocates, and they were doing SUD all at the same time.
Yeah,
so
exactly. Yeah, thank you.
Terry, did you have a hand up?
Yeah, thanks. Yeah, with the compensation issue, if there's unfilled positions, that means there's budgeted dollars for salary and benefits that haven't been spent. And I know that Mount Diablo Unified School District just signed a contract with their teachers, and they put in a three-pronged approach. They gave raises, they're doing signing bonuses to attract new people, and they're giving bonuses to those who are staying and committing through next year. Um, uh, yeah, and I think it takes all of that these days. The other piece is building relationships with folks who are in training as early as possible. I know some places are creating internship programs, so they're working with the students, building relationships before the students are even out of school. And so if we created that kind of partnership, it's a lot easier for them to continue as part of the organization.
I couldn't agree more, Terry. And this is a perfect segue into just another kind of creative option that's available. I happen to sit in for Patrice with the Workforce Development Board meeting providers. What was that, 2 weeks ago, Patrice? Something like that. Charles was, I think you were there, Charles. But one of the programs that was implemented, I believe it was Jed, who, and I can't remember his last name right now. One of the
Silver.
Thank you. He shared is a program that he spearheaded with EMTs. And what they were finding is that EMTs, you get calls for emergency services, and the service workers don't look like the people in the community. And so there are some kind of challenges with that. And so what they started doing was recruiting individuals from the communities that they live in to get trained as EMTs. And so everybody in this program got picked up by the EMT and the Ambulance Services Organization. And I just thought that was brilliant. The other thing that they have in place here is a career path for individuals who typically end up being low-wage workers to transition not just from an EMT, but into a paramedic role. The paramedic role is expensive. It's about $30,000 worth of training. But what he's established is a program for apprenticeship. And so rather than paying, individuals can move from being an EMT, and if they want to be a paramedic and their salaries double at that point, they can go through this apprenticeship program and learn to do that without taking on the debt that the program would require. All with keeping in mind, these are individuals from the community who may have previously been underemployed or unemployed, who have now a trajectory to serve their community. And at this meeting, I happened to ask him, I said, we are in such desperate need for forensic and mental health services. It would seem to me, in my mind, there would be, is there an opportunity to do something like this for our MET teams and to get people from the community, maybe individuals who have recovered and with lived experience with either the justice system or co-occurring disorders who are in recovery, to apprentice maybe as a forensic mental health clinician and work with law enforcement so that individuals, we can staff those positions, they get the training. And so I think there's all kinds of creative ways to think about it, but that was one that's currently existing for EMTs in the county. And I just think it's brilliant. So hopefully we can make a connection along those lines too.
Yeah, that makes so much sense. One of my sons went the route of EMT, and now he's a paramedic firefighter up in Sonoma. And he has an intern that he's training as a paramedic, because of their shortage. So I definitely get that. And yeah, I think, Charles and others have great opportunities as they're talking to those who are being released about this as an employment path.
Mhm. Absolutely. Jill.
Thanks so much. Great feedback. I, of course, have to be the wet blanket on all of this when it comes to salary discussions. So just to be clear, so we have county employees who are union employees. So advocating for salary increases, since you're an advisory body in the county, is not something you can do. Those are union negotiations. So just to be clear on that. And those are ongoing constantly. We just settled a few contracts in the last few weeks, and there's more coming up. So those are all part of the union negotiations. As far as salary scale increases in our CBOs, I think that's great, Denise, to look at the contracts, but really they determine their salary. So we really don't have any ability to say to them, you should pay your employees more. They have to determine. So I think working with the ORJ is awesome to determine what the needs are and maybe to better fulfill the needs. And if there's an increased need, to work with those CBOs to come back and ask for more services, which I will segue into my next point, which is yesterday was the Finance Committee of the Board of Supervisors. And I don't think anybody in the ORJ was in that meeting. And the reason why I'm bringing this up is there was the discussion of Stand Together. As some of you will recall, Stand Together has requested increase from the AB 109 budget quite a few years in a row. They're also asking for another $2+ million this next fiscal year. And what they do is deportation defense to our immigrant community. And so the nexus to AB 109 is challenging to make. And so this whole thing has been going on for several years. It was a pilot program and it transitioned to a standard program, and there's been no data. So they did provide some data yesterday. There's no nexus to AB 109. AB 109 funds are not limited. They could support programs like that, just like they could support many other programs in our county. But the question that was raised by one of the supervisors on that committee was, because it came up about the large surplus of funds in AB 109 right now. And there was some pressure put on county staff to address that surplus, because it's a very large surplus right now, far more than the reserves need to be. The reserves currently are put at by CCP 6 months of budget, and the soups did suggest, the two soups did suggest, or one of them did suggest that it be 1 year, that there be 1 year in reserves, which there's still ample surplus. And she also asked that there be an exploration to see what unmet needs are in the re-entry population, and spend it on that over Stand Together. There might be a one-time expenditure from AB 109 for this next fiscal year, but I think this is an awesome opportunity for all of you to really elevate this conversation, because there is a lot of unmet needs. There has been a lot of unmet needs, and there is a significant fund balance to help address some of those unmet needs. So it's an exciting time. I did share this agenda, as well as yesterday I shared the insight that I've gleaned from your conversations that housing, mental health, and SUD are unmet needs in this population with that supervisor's staff. So they are aware of it. This will be coming to the Board of Supervisors in mid-August to have a further discussion. So it's something somebody might want to put in their tickler on their calendar to be present for that discussion and perhaps provide their 2 cents. And then in addition to that, when you discuss the MET program, the mental health evaluation teams, I don't think people are super clear on what those are meant to do. Those teams are simply teams to follow up on crisis emergency calls. They are not structured to respond to crisis calls. They are the follow-up team. However, we do have our crisis response initiative. We have adult and both children's that have been up and running for quite some time and is being expanded. So we do have an enormous amount of money that's poured in from a variety of areas to build this crisis response program that is being expanded right now. It's, it's limited hours, but is being expanded and does have the funding to expand. And a whole lot of clinicians have been approved and are being hired to support that program. So a lot more coming out, a lot more to roll out in the fall, as well as really looking toward a sobering center, restoration center, and all of the rest that goes hand in hand with all of those things, exciting things happening in the future. So I think some of those things are being addressed, but I think when they talk about expanding the MET program, I'm not clear that that's a necessity. It could be, they might need to, but I think the crisis response program is what really people are looking toward, and it's different than MET. And in addition to that, San Ramon Valley Fire was approved for funding out of Measure X to expand their program to add a clinician into their system to do crisis response in the San Ramon Valley. Because they do recognize, as the fire chief there says, every single response they go to has a mental health component. Because when somebody is in tragedy, when some first responder shows up, there is some form of tragic circumstances. And so I think that's a phenomenal way to look at all of our first responders.
Hey, thank you. I'm going to have to step in here. We've got, I know we have questions. We've got a dilemma. I'm available to stay a little longer. This is extremely important. However, we've got two more potential questions between Nicole and Dale, or Dale first, then Nicole. We have some other agenda items that must be attended to. So why don't we do this? Dale, you've got a minute. Nicole, you've got a minute, and then that's it. Following that, we will go to the remainder of our agenda, and we will request that people give nothing but bullet points if at all possible. Dale, the floor is yours. The clock is running. 1 minute.
Yeah, thank you. Those of you who have CBO experience, I wonder if you think it could be helpful to have a workshop for CBO leaders on recruitment of people and also determining appropriate wage levels. Now just throw that out for later consideration.
Dale, thank you for your comment. Let's move to Nicole Marie Green. You now have 1 minute, and I hate to do this.
No, I'll hold mine. I'm pretty sure it was questions for Jill Ray. I'm pretty sure on one of our next meetings, I wrote down my note and I'll ask her then.
Okay, Nicole, thank you so much. And I hope I wasn't rude to cut off the conversation. Christina, wow, what a presentation. Denise, wow. Oh my goodness. So thanking you in advance, but let's move now, hopefully, to some subcommittee and external meeting information. If we could ask, I realize there's quite a bit on the screen for PPC. Give us some bullets, 45 seconds to a minute, and let's move on. For example, may we start with Board of Supervisors. Jill, succinct, if you would, please.
I can make it really succinct because there's only been 2 meetings. So the DA received a grant for $1.3 million for the resentencing pilot program. So that's exciting. A lot of contracts were approved for upcoming fiscal year, and the Board of Supervisors continued virtual meetings at each of their meetings. The last thing I wanted to announce is that Candace was selected to participate in the National Association of Counties Familiar Faces program. Denise is going to be an integral part of that, as will I, and it really addresses this CalAIM population as well, and familiar faces being those faces that we see revolving through our systems of care. And the last one I already told you, it's the Finance Committee, so that concludes my report.
Jill, great, you set the stage. Okay, who's next? Scott, PPC, let's roll.
That is me. We're rolling.
Okay, Scott.
So the June 27th meeting that started at 10:30 a.m. for the Public Protection Committee was chaired by Supervisor Federal Glover and co-chaired by Vice Chair Supervisor Candace Anderson. As you can see in my document, Mika Herrera from West County is being, her name is going forward for the Juvenile Justice Coordinating Council to be considered by the board as an at-large representative. You can also see for the Racial Justice Oversight Body that Gigi Crowder from East County and Carlos Fernandez from West County, they're approved for that board. We have the acceptance AB 109 evidence-based reentry housing program RFP. And I was just thinking, Denise, are you still on the call?
Yes, I am.
Can you give a word or two? Because no one can do it better than the person that did the report. And that was for the housing.
Well, can I do it on her behalf?
Yeah.
Okay.
Patrice is more diplomatic than I am.
All to say that this was a award recommendation made by a panel of folks who reviewed all the applications we received for our evidence-based reentry housing program. And this was then presented to the PPC just to give them an update on our process and to hear any feedback they may have. They referred it over to the Board of Supes, which was one of the approved contracts that Jill mentioned this past Tuesday.
Excellent. All right, thank you for that. So item number 7 on that agenda, as you can see, was from our public defender, Ellen McDonnell, and she presented on the holistic intervention partnership and early representation programs, and reported with wanting to continue those two, which are recognized by the state of California as exceptional programs. And I can just say, it was such a good presentation. It was so heartwarming to see that we're doing some of the things that we are, corroborated this morning by Christina and Emily and Denise, by all of the efforts to reduce barriers and silos by agencies in the criminal justice and other systems to support people who have been arrested and booked and needing representation. And it's certainly come clear that so many people that go through that back door at the jail also have addiction, mental health, physical, psychological, and some sexual abuse, often dealing with meager financial means, housing issues, and transportation issues. Excellent presentation and effort by all those agencies to deal with those.
Scott, could we wrap this up, please?
I'm done.
Great. Good timing. Hey, Scott, you nudged me. All right. Thank you so very much, Scott. May we now move to, see, I got to give you time for your next presentation here, Scott. We're going to move to outreach and community engagement, our subcommittee report. And we want to start here with item number 1 here.
Right.
And, okay, would you first give us your outreach and community engagement, and then I'll introduce the membership vacancy.
Oh, well, sure. I mean, OCEC had to consider nominating one of the 3 great alternative candidates, and Reverend Van Hook, Joel Nickerson Shanks, and Michelle Carter. And our group met and felt all 3 had equal standing, but the seniority went to Michelle Carter. And if you want to say a word or two about that, Crawford, you go right ahead.
No, I think you covered it. And also maybe we could add one more item. She was basically justice involved, so she can bring a little additional insight. And finally, please be aware that Michelle is not with us. She had shoulder surgery, elbow surgery, and wrist surgery today. So we hope she's doing well. We've already reached out to her, but we welcome her. However, before we can welcome her, is there a motion to approve the recommendation?
Yeah, I was going to make that motion. I move that we approve Michelle Carter as a full voting member of the CAB.
Is there a second?
Dale seconds.
Is there any discussion by the board? Is there any public comment or discussion?
The only public comment I would add is just to be clear to everyone that that will go to CCP. I believe the next meeting is September, right? So
Correct.
that will be then official once that goes to CCP.
Correct. This is just a recommendation, Jill. Monique, would you be kind enough to call the vote?
Absolutely. Just 1 second. Let me go to the roster. Crawford Carpenter,
Aye.
Dale,
Aye.
Ozzy,
Aye.
Nicole G,
Aye.
Lanita,
Aye.
Nikenya,
Aye.
Scott,
Aye.
Mark, I'll come back to Mark. Terry,
Aye.
Joel,
Aye.
and Mark.
Mark may have had to drop off, but let's keep moving.
Okay, so motion passes with 1, 2, 3, 9 yeses and 1 non-vote. But
Thank
it
you.
passes.
Okay, the
Thank
motion
you.
passes. We will take Michelle Carter's name to CCP for approval at their next meeting. Thank you. The next item on the agenda, Scott, you're up
Yeah,
again.
number 2, CAB ambassadors program assignments, and I'll move this to Monique, who will discuss.
Okay, so what we have here is the CAB ambassadors assignment, and we have a schedule that we need to fill. So we would like to have 2 people in each category, and some we have we're missing in some of the categories, as you can see.
Monique, could you please enlarge it for us?
Okay, absolutely.
It's really difficult to see. Thank you so much.
The goal is for us to fill these spaces up today. And what I'd like for the members to do is to please let me know where you would like to be placed.
Could you still enlarge it a little bit more?
Is that good, or does it need to be enlarged more?
It needs enlargement.
Okay.
Thank you, Denise. I thought I was the only one that couldn't see.
No, I'm.
No,
Monique, if you change the percentage on the PDF to 100% by the plus sign.
Yeah, usually 150 is.
I think I put it on 150 now.
It might be on a different screen, the one you're sharing.
Oh.
Because we still see it at 75 on our end.
Oh, okay, okay.
Thank you.
Okay, hold on, let me, well, while I'm doing that, for those that can't see the screen, at the lower amount, if you could please think about where you would like to.
Right.
Is that bigger?
No.
No.
It's still not bigger, okay. Well, maybe let me stop sharing and then come back. I think that's what it is, my screen is paused. Okay, so let me share now, but if you all could please think about that.
Oh, there you go.
Okay, good, good. Maybe it's a little bit too large, but that's okay. So,
could I make a suggestion that since we have 6 minutes, that maybe this get emailed out and we fill it out after the meeting?
I am okay with that. How about you, Chair Carpenter?
That would be fine, yes.
Okay.
And again, now let's be clear on what we're trying to do. You'll notice under the court system, we only have one person go over to probation. We have 4, so we only need 2. So maybe somebody could help us with the court and then go over to the sheriff's office. Okay, we're okay there. Go over to Joya. We have 3, we only need 2. So we just need to move some people around a little bit so that we get all of our partnerships taken care of, as well as our supervisor. For example, Burgess, we only have 1, but you know, we can work that out, or I don't mind moving from one area, maybe to Burgess from Goya. Just get your preferences in there, but this is most important. We've got to get going with the ambassadors program. Thank you.
Thank you. Okay.
And just something to note as you're calling to make appointments, it's Burgess with a hard G and Joya with a soft G. So
Joya Burgess. Okay. Thank you, Jill.
Right, and Crawford, with the last thing here is just a notification to everyone. Included in the packet was our slideshow, our PowerPoint, and it's available now for everyone's usage when they're doing public outreach. Ding, done.
Wow. Scott, you're good, man. I like that. I know we picked up the pace here a little bit for everybody, but we can come back maybe at the next meeting day. Scott, if you want to cover the PowerPoint, but it's there. We have comments for you. Scott, thank you so very much for taking the bull by the horn there and bringing that together for us. May we now move to the next item on our agenda. Dale. Good morning again, Dale, or wait a minute, we're almost afternoon. Would you give us a brief minute summary of what's been going on at programs and services?
Dale's on mute.
Dale, you're muted.
You're on mute, Dale.
Shoot, sorry. I want to be real brief about this. I just want to highlight Denise's work in the survey, and that I'm really pleased with the number of respondents. And so I think of all of this, that's the main thing I want to focus on.
Geez, Dale, you left time for someone else. Dale, I love it. Thank you so much, Dale. And again, Denise, we can't overly state the importance of the work your office has done there. Phenomenal. Great.
It is a team effort, so thank you.
Okay, and now let's move, if we may, to policy and budget.
Okay, and this is Ozzie Carter. I was sitting in for the chair, and I'm going to keep it very brief. Our discussions primarily are reviewing our CAB budget. And we had the opportunity to have paperwork from county agencies, and we reviewed the dollar amounts, and we discussed any overages and underages and tried to figure out what our game plan is in the future for developing and overviewing the upcoming budgets from our CBOs. And I'm going to pass.
Thank you, Ozzie. Man, this is too much. Okay, Dale, you're up. The next 2 items on the agenda, if you would first cover homelessness for us, followed by Measure X. Floor is yours, Dale.
You're muted, Dale.
Darn it. The figures speak for themselves there. So I just think that you can focus on the number of people that were identified in the point in time count totals. And it's really disappointing, but great that people do the job so that we have an idea. And then there wasn't anything on Measure X. The next Measure X meeting is next Wednesday. And so I will be attending that. And so I can report then later on that.
Okay, does that cover both of yours then? Homelessness as well as Measure X?
Yes.
Okay, thank you, Dale. And prior to adjourning here, we're going to pause 1 second. We've rushed to get to this point. Now we got to take a deep breath, or at least I do. Prior to adjourning here, I think it's most appropriate to thank our presenters. Our presenters have done just a fabulous, outstanding, wonderful job in bringing information to us that I think it's just so sorely needed. So with that being said, thank you, thank you, thank you. And you will get a personal note, each of those presenters from us. Let's move to the next item. And this is on another note here. Let's remember that we are here to mentor each other, and doing so allows us to provide a broader voice for those we are here serving. And by George, the presentations indicated who we serve and what we need to do for them. As always, let's continue to be focused, and undoubtedly, that will lead to our collective success. And now, and I'm going to do this very slowly, one of our own, Nicole Popchek, will be leaving us and heading to Boston, of all places. I personally would like to thank Nicole for the tremendous support that she has provided to CAB. And on a personal note, I will sorely miss her 7 a.m. calls while she's driving to work. And I'm just waking up, but by George, believe it or not, we did get a great deal accomplished at that hour of the day or the morning. The mic is open for any of you who want to share any comments pertaining to Nicole.
Well, this is Dale, and I want to say that I have consistently been amazed at the detail and efficiency that Nicole has demonstrated. Going to miss you, Nicole.
Thank you, Dale. I'm here.
Oh, you are? Oh, there you are.
I am here. I'm already crying, so I don't think you need to see my face.
Well, don't cry. Are there any other comments?
This is
Nicole,
Nicole. Oh, I'm sorry.
Right.
Okay.
Go ahead.
Go ahead, Terry. Were you going to say something?
Okay. Nicole, I just want to thank you for everything. You're incredibly welcoming as I came onto the committee. You're a total pro, and it's a great loss for us here. And Massachusetts is lucky. Maybe you can help thaw things out up there.
Thank you, Terry.
Was there anybody else?
It's Nicole. Nicole already know I shared how much I'm going to miss her, but I am going to be missing share my name with someone.
Yes.
So
No more Nicole Marie. You can have Nicole now.
No, you missed it. I have to do that at work. I came here and there's other Nicole here, so I am still Nicole Marie.
Oh, okay.
But I'm surely going to miss you and working with you. You and Monique always keeping me on my toes. So I just want to say, I wish you and your family the best of luck, and I will definitely miss you.
Thank you.
Well, I'm going to have to chime in too. I'm going to really miss you, Nicole. It was a pleasure meeting you. I've met you in person, and shared some really great things with you. And I'm going to miss you because, you know, it was getting my feet wet here. You really helped me and have helped to mentor me. And yes, I concur. Boston is really lucky. They're lucky to get you.
Thank you, Ozzy.
Hey, Nicole, it's Nick Kenya here. I am also going to miss you. You were the glue to this whole thing. And as the person previously said, when I was new here, you basically were a very good in guidance. You know, you're supportive, you're personable, and I wish you the best of luck in wherever you go.
Thank you, Nikenya.
Any other comments? Well, with that, one other comment from me. You're welcome to call at 7 a.m. I want to make sure you know you're welcome. Just make sure it's not 7 a.m. your time. Make sure it's 7 a.m. my time.
I'll remember that.
Okay, and with that, hey, we've so appreciated what you brought to the party. And with that being said, the very best to you and your family. And this meeting is adjourned to our next meeting, which will be August the 11th at 10 o'clock. And Nicole, the Boston, well, I got it now. Boston Nicole, you are more than welcome to join us. With that, have a good day.
One quick thing, Crawford, can I jump in?
Oh, yes.
We are, it just as a way to send her off right. Luckily, it's not too cold over there at this time of the year, but we can at least send her off with a few cool drinks. So we are hosting a quick get together after work at 4 o'clock on Monday at Jack's here in out in Pleasant Hill. You all are invited if you'd like to send her off well, particularly in person. I know she hadn't had an opportunity to meet all of you in person. So for those of you who can attend, let me know in advance so we can kind of monitor numbers here, but certainly want to invite you all to join us.
Thank you so much, Patrice. And with that, we are adjourned. Thank you.
Bye, everyone.
Bye.